esteemed chairperson, Dr. Sheetal Chaudhary ma'am, to continue with the proceedings of the scientific session and introduce our distinguished keynote speaker, Dr. Rachna Rath ma'am.
A very good morning, all of you. We are privileged to introduce and welcome Dr. Rachna Rath, a distinguished oral and maxillofacial pathologist. She holds a fellowship in forensic odontology from SDM College, Dharwad, and completed her MDS from Narayana Dental College, Nellore, where she was a university, including keynote lectures at national forums, and has received multiple Best Paper awards. Her research collaborations with IIT Kanpur, IIT Bhubaneswar, and leading cancer institutes reflect her commitment to interdisciplinary advancement. Currently serving as Associate Professor at SCB Dental College, she has contributed extensively through impactful publications, academic leadership, and community oral health initiatives. Dr. Rachna Rath truly exemplifies excellence in scholarship, leadership, and professional services. I request ma'am to kindly start the session.
Thank you so much for the kind words, ma'am. A very good morning, everyone. I feel greatly humbled already to be making this presentation before the stalwarts, legends, and prominent pathologists on and both off the days. So with the blessings of Lord Jagannath and the permission of my chairperson, may I begin. How is the weather here today? How is it going to be in a couple of days or weeks from now? How is the climate here going to pan out in a couple of years from now? So predictions. Meteorology and metastasis seem to have met at one common point today, and that is what started with just a couple of variables, like the Babylonians predicting weather by watching the appearance of the clouds, to present times when there is a multiplicity of variables to do the same. Satellite, radar, weather balloons, why, even numerical models, and yes, synoptic reporting. Not much different from prognostication in oral cancer. The better the predictions, the better the chances at survival, be it a natural calamity or cancer. On that note, what is a prognostic factor? It's a variable that independently correlates with the disease outcome or prognosis. It will tell you how aggressive the cancer is likely to be, how it's going to behave regardless of treatment, and what will be the patient's chances of survival, recurrence, or metastasis. There can be a whole range of different prognostication tools like nomograms, risk classification systems, equations, risk scores, and so on. So prognosticators in oral squamous cell carcinoma constitute a whole range of patient-related, treatment-related, and yes, tumor-related factors that may be clinical, pathological, or molecular in nature. And they have their impact on a whole range of different prognostic outcomes. Now, as oral pathologists, we delve day in and day out into the routine HIT stained sections of cancer samples, trying to extract the maximum prognostic information out of them, right? So this presentation today is about the histopathological prognosticators that are currently in use and a few others that show promise. So peering more for peerless prognostication in oral squamous cell carcinoma. Landmark studies and sentinel work brought us some of the early histopathological prognosticators, like Brodus grading reverse tumor differentiation. Then came Jacobson's and Anirudh's multifactorial histological grading. Many others soon followed, each trying to more objectively define the parameters than the ones before them. Up until the point of 1989, when Bryan proposed the invasive tumor front grading, it outperformed whole tumor grading. Risk classification or risk assessment models came in. Like, if I remember where Mishra sir yesterday pointed out, categorizing patients into risk groups as the good, the bad, and the ugly. Well, yeah, they even had a more specific purpose like the HRA model. It sort of addressed the need for adjuvant radiotherapy, or the popular BD model. It focused on tumor cell dissociation. Integrative risk models started happening, and since the last decade, incorporating tools of machine learning, combining a plethora of clinical, pathological, and molecular variables. These models, however, get a bit restricted by issues of subjectivity. The TNM AJCC system of staging was introduced a long time back, and it sort of harmonized things. It gave a universal classification scheme, not only for the treatment of oral cancer, but also its prognostication. Currently, into its 8th edition, it's more prognostic than it's ever been before. And yet, questions are raised on its adequacy. And this is where the other tools step in to supplement the TNM staging. We investigated 3 such important histopathological scoring systems to test their association with cervical lymph node metastasis in our sample of 507 early stage oral squamous cell carcinomas. The Martinez-Gimeno system, the BD model, and the more recent Aditi-Nuzhat lymph node prediction score system that's been exclusively developed in the Indian population. While all the 3 models were showing significant association, it was the Martinez-Gimeno one that showed a more robust one, with an 82% correct classification rate. But when it came to survival, the BD model fared better. So given these kind of findings, it was only natural for us to evaluate the parameters and develop our own predictive model, which we did, and that is currently undergoing validation. So on that note, I will begin by discussing each of the pertinent parameters one by one, starting with a very basic tumor grade. Tumor grade refers to the tumor cell phenotype and the level of differentiation. So it's already well established that with increasing grade, there is a worsening outcome. So although a prognosticator in OACC, when used alone, it has little influence on tumor prognosis. Battles have formations, and so do invasions. They have patterns, and you may have rightly guessed, the next parameter is the pattern of invasion. So this refers or implies the loss of contact inhibition, and it is an index of epithelial mesenchymal transition. It's been an important factor in many rating and scoring systems. So broadly, we have 2 types, the low invasive cohesive type, which is constituted by the WPOI 1, 2, and 3, and the more invasive non-cohesive patterns. The worst pattern of invasion 4 and 5, out of which the WPOI 5 category stands out as a very adverse prognosticator. Now earlier, the predominant pattern of invasion, or PPOI, was assessed. Now this has been entirely replaced by the concept of the worst pattern of invasion. That represents the most aggressive pattern present anywhere along the entire invasive front, regardless of its proportion. And truly, the non-cohesive patterns also associate with the other adverse prognosticators. Sometime back, we were examining the lymph node reactivity patterns in our sample of OACC and found the WPOI 3 and 4 patterns to strongly correlate with an advanced tumor stage and the germinal center predominant lymph node reactivity pattern that's commonly seen in metastatic nodes. We have then inferred that pattern of invasion may be a surrogate marker for predicting lymph node met. Now, the 8th edition of AJCC considers WPOI 5 with the invasive front as a prognostic factor, at least an additional factor that needs documentation. And what do you think would be the implications of finding a WPOI 4 or a 5 in pre-operative biopsy? Because sometimes you do. Huge implications. Because it would require for the surgeon to place wider margins at the time of operation. So, integration of this kind of information about WPOI is routine evaluation imperative to identify the high-risk patients. And now high-end data already points to the fact that the non-cohesive patterns are significantly associated with greater recurrence and worse survival as compared to the cohesive patterns. So when there is an attack, there has to be a response. And this brings us to the parameter of host lymphocytic response. So it is the response of the host against tumor growth. Traditionally, we've been quantitatively assessing the density of lymphocytes at the invasive tumor front, categorizing it, documenting it in our reports as intense, moderate, or mild, or if you're following the HRD model as a strong, intermediate, or weak. Nonetheless, patients either with a mild or a no lymphocytic infiltrate, they are associated with a poorer survival as compared to those who show a brisk immune response. And in this context, I will specifically talk about the tumor infiltrating lymphocytes, that there is specific immunoreactivity to the tumor cells. So increased levels of these TILs, better prognosis. Now guidelines have also been placed for assessment of these TILs, and a particular study proposed a cutoff point of 20% to delineate between the low stromal and high stromal TILs. Low stromal TILs again adverse prognosticator. We were investigating the expression of PDL1 in our sample of tobacco-associated oral squamous cell carcinoma and found positive PDL1 expression significantly associated with moderate to marked TIL levels. And surprisingly, the overall survival rate in our sample showed a declining trend with an increase in the level of these TILs. So this finding was not significant, but like many authors before us, it made us infer that probably the phenotype and not the number of the inflammatory cells in the immune microenvironment is prognostically important. So we then come to the TIL subsets. And we already know this, that certain subsets are associated with a better overall survival, the CD8 plus T cells, memory T cells, natural killer cells, while others like the CD163 plus, the M2 macrophage lineage, the FOXP3 TIL, the Tregs, associated with a poorer prognosis. No wonder then that the group who discovered Tregs bagged the Nobel Prize in Medicine for this year, right? So, TIL subsets by themselves and their spatial configuration. This has been the subject of some very recent research also, and there's an immunoprofiling that's been forwarded that has categorized them into three groups. So you have the immune desert or the cold phenotype, barren immune microenvironment, no immune response, no TILs, worse prognosis. And this group will not even respond to immunotherapy. There's no PD-L1 expression either. Next, you have the immune excluded one, brisk immune response, a lot of TILs in the peritumoral stroma, good prognosis. And since there is some amount of PD-L1 expression, we will also probably benefit from immunotherapy. Most interesting is the category of the immune inflamed or the hot phenotype. Now, you have a large number of TILs in this particular category. Not only in the peritumoral stroma, they're infiltrating into the tumor parenchyma, and yet the prognosis is bad. So this just underlines the fact that the T cell subsets are more important than its numbers. But since they are also, showing a good PD-L1 expression, they probably will benefit from immunotherapy. So just imagine what kind of therapeutic implications these kind of immunoprofiling carry, especially in today's time or era of personalized and precision medicine. Yeah. So with that, we come to the next parameter, like many speakers yesterday mentioned. It's been the bone of contention between the surgeons and the pathologists. Yes, it's the surgical margins. So guidelines dictate that adequate resection is that where there is clearance from gross tumor and permanent margins at 5 millimeters, which would mean there has to be removal of healthy palpable normal mucosa around the tumor to the extent of 1 to 1.5 centimeters. Now our guidelines, we know, RCPAP, it gives provision for a closed margin. Anything above 5 mm is a negative margin. CAP guidelines, presence of tumor or high-grade dysplasia acting or at the margin, that's a positive margin. Now, so we go ahead and use these guidelines and do the measurements. Irrespective of there being histologically normal margin, many a times there are molecular alterations which are very well captured by a number of different molecular markers. We investigated the same with survivin and cyclin D1 in our sample. So survivin was expressed in 43% of these histologically normal margins, while cyclin D1 in 36% of those. Survivin positivity in our sample in these histologically normal margins was associated with a 91% recurrence rate. Cyclin D1, 100%, meaning all cyclin D1 positive margins they record. So this is very important prognostically. But then this kind of evaluation cannot be a part of routine workup for regular cases. So we will have to come back to the question of optimal cutoffs. And that is currently regarded as the 5 mm threshold. Even this threshold has been contested. Cutoff values ranging from 1 to 7.6 mm have been used with success in the oral cavity. And a recent meta-analytic data shows that when they try to assess the surgical margins in OSCC by 1 mm increments, what they found was, although below 4 mm, the risk for recurrence was significant, between 4 to 4.9 mm. It was similar to that of the 5 mm cutoff. So this blurs the line between the closed and the care margin. And as if this is not enough, comes the dynamic cutoffs. They challenge the very concept of static cutoffs, and I'll be visiting that at a later slide. Well, I move to the next parameter, and it's the third route of metastasis. Any guesses? Perineural invasion. So its incidence in OACC documented somewhere between 16 to as high as 30%, even in its early stages. So traditionally defined as in, around, and through the nerve, more objectively defined as a tumor in close proximity to the nerve, involving at least 33% of its circumference, or cells within any of the 3 layers of the nerve sheath. Pathogenesis of PNI involves a reciprocal growth interaction between the tumor cells and the nerve, facilitated by a number of different molecules, nerve growth factor, neurotrophin 3, and so on. We all know. It has shown to be an independent predictor of neck met recurrence and worse survival, and yet reporting of PNI is not mandated as per AJCC guidelines. But we do report them because CAP and RCPAT, it's a required component, and it's not just the presence or absence of PNI. It's important to document involvement of small nerve versus that of a large nerve, focal versus multifocal involvement, and even intratumoral or an extratumoral involvement. We need to document all of this in our report. Now, in the HRE model, PNI of a large nerve itself takes the risk score up to 3, which means there is a need for adjuvant radiotherapy even if the margins are clear. And the way molecular mechanisms are getting unraveled, there's a possibility that targeted therapy will soon develop in these PNI positive OACC subsets. When we're talking of the routine or the usual routes of metastasis, we cannot miss lymphovascular invasion. The very presence of tumor cells in the vascular compartment indicates there is a potential for development of metastasis. The incidence of this is 10 to 20% in the OACC surgical specimen. Sometimes it's a tad bit difficult differentiating between a blood vessel and a lymph vessel, and it's not routinely that you use the immunostains. Separate estimates of both are currently not required as prognostic indicators, but reporting LVI, that is important. Even though it's focality, again, that's optional. So it's a promising prognostic feature of other cancers. Data shows that presence of LVI is associated with a very worse survival, so yes, it's an important parameter that needs reporting. I now come to twin parameters, the implications of which are profound and deep. Any guesses as to what the parameters might be? Postgraduates. The depth of invasion and tumor thickness. So the association of thickness, depth, and tumor invasion is a 100-year-old concept. Since the 1980s, DOI has been used to make decisions regarding END as well. And yet both the terms had been used synonymously in the past. Until some time back, they were clearly differentiated. So tumor thickness is the measurement from the surface of the epithelium, and DOI is the same from the basement membrane of the angiosyndrome normal mucosa. All of you know that. So DOI is currently in the T category of the 8 TLM at 5 and 10 mm cutoffs. And why is that so? Based on a large body of evidence, which clearly shows that it predicts nodal met, recurrence, and survival. Yet there are a few studies who state that irrespective of depth of invasion or tumor thickness, being a T category modifier, the prognostic performance of the TNM staging as per 8th edition is similar. And these very studies, they recommend that tumor thickness can be substituted in place of DOI, especially when there are challenges in its measurement. And there are plenty of challenges in the measurement of DOI. Many pathologists would have experienced that. So we conducted a survey among oral pathologists and got this kind of a response. So these challenges pertain to an undulating epithelium, mucosa on multiple sides, especially the problem of convoluted or even a perpendicular mucosa. So these challenges need to be addressed. The second concern regarding DOI is the optimal cutoff value to take decisions regarding END. Currently it's regarded to be 4 mm, though certain guidelines even propose a 3 mm cutoff. So this debate goes on, and we investigated the prognostic significance of these DOI cutoff as per different subsites in our sample, and we agreed, our results agreed with the previous 4 mm cutoff, at least in early stage OACC. And well, there have been other studies, however, they have found significant site-specific DOI cutoffs, like Brokaw study gave a 2 mm figure for town, 4 mm for RMT, and so on. This debate is far from over, but yet DOI is an objective and promising pathological predictor. Now, there is another interesting area where a lot of research is currently going on and must be taken further, and it's the subset of oral squamous cell carcinoma occurring in the background of OSMF. Such a Southeast Asian and Indian subcontinent problem, isn't it? Because of the habit of beetle cool. So how fibrosis in the submucosa affects the depth or influences the depth of invasion, how the DOI cutoffs are going to vary in different subsites in this particular subset, it's worth investigating because the biological behavior of this subset is different from OACC that occurs without OSMF. So yes. Now some ongoing research on novel markers have exploited the depth of invasion parameter. And therefore we have the margin to depth ratio and similarly margin to tumor thickness, margin to tumor size ratio. MDR of course prevails. The larger question here is, do all tumors of varying depth need to have the same clearance? And the answer is no. Smaller tumors perhaps need less clearance, the deeply invasive ones requiring a proportionately larger clearance. So a study with a very large database, it actually showed a cutoff MDR of more than 0.5 strongly correlating with survival. And similar studies recommend that safe surgical distance should be calculated from the depth of invasion and traced. Dynamic resection margin criteria. So dynamic cutoff versus the static cutoff of 5 mm. Now you go figure. So we investigated this in our sample recently and have interesting findings. I move on to the parameter of tumor budding. Now, tumor budding is the presence of a single cell or a cluster of less than 5 cells at the invasive tumor front. Very often we need resorting to cytogenetic immunostimulators to identify them, especially when the stroma is inflammatory. So high tumor budding, that's presence of more than 5 such tumor buds at a hotspot, is strongly associated with nodal met and worse survival. We tried investigating the phenotype, and the ALH1 expression both inside and outside the budding area correlated significantly with the tumor budding intensity in our sample, thus suggesting that they have a cancer stem cell-like phenotype. Now, tumor budding is an important prognostic marker in colorectal cancer, and the tumor budding consensus conference recommends that this should be a part of routine HPV evaluation even for oral squamous cell carcinoma. However, there has to be more standardization of its evaluation method, whether a 2-tier or a 3-type system needs to be used until it becomes a more formal prognosticator. And there's one more point I'd like to add here, that tumor budding is mainly associated with a non-cohesive worst pattern of invasion 4 and 5. So if you are infrequently observing this in the context of a WPOI3, which you will, so it means that it's probably transitioning into a worse pattern. I now come to the most important, single most consistent prognosticator in OACC, and it is lymph node metastasis. And why is that so? Because patients with even a single metastatic lymph node are put in the advanced disease category, and there's a 50% decrease in overall survival. Current N category of itsdentalmuradnagar takes into account the positive number of positive lymph nodes, size of the metastatic deposit, laterality, and EM. But there are other nodal features that matter, like the lymph node yield, the lymph node ratio, tumor node ratio, logons of positive lymph node, the level of lymph node involvement, tumor volume, and so on. So, as with an increasing level of lymph node involvement, especially levels 4 and 5, there is a worsening survival. When we come to lymph node yield, it's been shown that a yield of more than 18 during neck dissection is associated with an improved survival. And current recommendations are that if there is a selective neck dissection, the minimum nodal yield should be of 15, and if it's a comprehensive neck dissection, it should be a 22. These figures have risen from the earlier ones of 10 and 15 respectively. Lymph node ratio. Higher is this ratio, consistently it's predicted poorer survival across pooled studies. The number of positive lymph nodes. This has drawn a lot of recent research, and entire staging schemas have come up taking this factor into account. Of course, they need more validation. Size of metastatic deposits. Larger deposits, higher risk of healing, poorer survival, right? So, I'm not just talking macrometastasis here, even micrometastasis. It's an adverse prognosticator, but detecting micromet is sometimes tricky in routine LN processing and evaluation. So, we investigated the same in our sample, combining step serial section with cytokine staining. 6.6% cases were upstage in our cohort of tongue cancers. So EGCC recommends there needs to be more research in this direction, not just about the detection, but also the prognostic significance in OACC even more. When things get out of hand, or the node, they will extend, and this brings us to the parameter of extranodal extension. This has emerged as a very important adverse prognosticator, especially of late, and it's made its way to the N category of the HTLM on the basis of its presence or absence, but not due to a quantification of its size. And size does matter, doesn't it? So as per size, ENE is again categorized into ENE minor or a microscopic ENE and an ENE major, when the metastatic deposit reaches the lymph node capsule beyond 2 mm. So this has a lot of prognostic weight, and we need to document this in our reports. So the presence of an ENE, in fact, is also an indication for adjuvant chemotherapy that needs to start within 6 weeks post-surgery. Speaking of tumor cell characteristics, One parameter is sometimes underrated, and it is the tumor stroma, which of course has gained a lot of attention in recent times. And I'm not just talking about the quantity of stroma, but also the kind of stroma. We have been documenting this for a long time, whether it's of the myxoid variety, hyalinized or desmoplastic, especially the presence of a severely desmoplastic or hyalinized stroma, it's an adverse prognosticator. And it has implications for therapy. There will be a development of resistance to therapy in the patient later on as well. Cancer-associated fibroblast, they remodel the EC. More stroma, more stromal growth factors aids or propels tumor growth and invasion. So now data shows that stroma-rich tumors with more than 50% of stroma, there is a specific calculation for that, and a low tumor-stroma ratio consequently. This is associated with adverse prognosis. Again, an area, attractive area for research, especially correlating this with the other adverse prognosticators. I come to the last parameter of the day, and that is bone invasion, involvement of the bone. Directly upgrades the tumor to a T4 stage. Broadly, two categories we know those are infiltrated. The later type associated with the poorer prognosis. As to the extent of it, various studies throw up various results. Mandibular medullary invasion better than mandibular cortical invasion as a prognosticator. Mandibular canal invasion better prognosticator, and so on. All in all, bone involvement is a marker for advanced tumor stage bad prognosis, but association of its pattern and extent with prognosis, that needs more research. Now, there are a myriad histopathological parameters that have not been touched upon in this presentation. I went with the more pertinent ones due to a dearth of time. These parameters also get a bit limited by issues of subjectivity, a lack of clinical comprehension of the results, and generally by a lack of adequate validation across population studies, institutions, centers, and so on. And yet, I will conclude saying that histopathological parameters remain the cornerstone of OACC prognostication. There are clinically impactful predictors that must be documented, like the depth of invasion, pattern of invasion, PNI, LVI, marginal and nodal characteristics, and to an extent even tumor burden and tumor stroma ratio. Newer concepts, the dynamic ones, they are emerging. Only time will prove their prognostic efficiency over the static cutoffs. Meanwhile, we adopt a synoptic, multi-parametric approach, integrating tools of histopathology, molecular biology, and immune markers. That will perhaps take us as close to Paris prognostication as possible. In this era of AI, how can I not talk about AI in the end? So, as more and more tools of machine learning are getting applied to traditional histopathological parameters, it's going to improve the objectivity in interpretation. And on that note, I close my presentation, thanking the organizing committee for this wonderful opportunity, acknowledging my postgraduate teachers and my entire department of SCP for the constant support. Thank you so much.
Very good morning, and it was very, I can say, a fantastic presentation from your side, ma'am. Thank you for briefing us about the various prognostic markers used for oropharyngeal carcinoma. Any questions from the audience? Invited.
Yes, actually. Good morning. Use the
Reparative or erosive type?
If it's possible, yes. You see, actually, yeah, we use a bar doesn't want to cut the sections, and so it's possible. Probably measuring the centimeter, how much may not be, but the pattern, yes, it's possible. We don't, of course, insert the entire mandible into the calcifying solution, but we take entire slices.
And one more, there are few even like studies where there can be carcinoma in salivary gland tumors as well. So depth of invasion is a very challenging.
It is.
It's very. There have been some reports where they try to do taking a depth of invasion in those way. They take the tumor thickness and go upwards to the thickness. So I don't know like how whether they use that as a depth invasion in the
No,
tumor
we
site.
don't. We take it from the adjacent, like I said, if you detect, you know that. So it's challenging. So currently what we're doing is where it's not possible at all. See, if it's a T4, you don't need, like, it's already, yeah. But early stages, if there's such a problem, lateral border of the tongue, mucosal surface of the lip, you can have these problems. We go for the tumor thickness. Document the tumor thickness and it's up to the clinician what they want to do with that information.
Thank you, ma'am, for such a comprehensive session and with a lot of clarity, also raised right questions and problems associated with assessing the histopathological prognosticators. Thank you, ma'am.
Thank you so much, ma'am, for such an insightful presentation. I'm sure the audience is enriched with this valuable knowledge after the session. May I now request our chairpersons, Dr. Kunal Shah sir and Dr. Sheetal Chaudhary ma'am, to present a token of appreciation to our esteemed keynote speaker, Dr. Rachna Rath ma'am. Moving on, I now request Dr. Nadeem Jetty sir, President-elect, to present a token of appreciation to our chairperson, Dr. Kunal Shah sir. I also request Dr. Nadeem Jetty sir to felicitate our chairperson, Dr. Sheetal Chaudhary ma'am. Thank you so much, sir. Moving on to the next international guest lecture by Dr. Ujjwal Bhawan sir on the topic the cancer clock, deck 1, deck 2 and hypoxia in tumor progression. To chair the scientific session, we are privileged to have with us Dr. Mala Kamboj ma'am. Ma'am, I request you to kindly grace the stage for us. Professor Dr. Mala Kamboj is currently serving as the Senior Professor and Head, Department of Oral and Maxillofacial Pathology at Postgraduate Institute of Dental Sciences, Rohtak. A distinguished academician with over 20 years of teaching and research experience, her academic and research accomplishments are exceptional, and she has guided and co-guided numerous postgraduate dissertations and organized and participated in numerous conferences and workshops. She currently serves as the chairperson of the research cell at PGIDS and the nodal officer of the Oral Pre-Cancer Laboratory under the Ministry of Health and Family Welfare. Thank you so much, ma'am, for honoring us with your presence today. Please give a huge round of applause to her. Accompanying her as chairperson is Dr. Pushpraj Shetty, sir. Dr. Pushpraj Shetty, sir, is an accomplished oral pathologist and senior faculty at A.B. Shetty Memorial Institute of Dental Sciences, Mangalore. With over 25 years of academic experience, he completed his PhD from Christ University, Thanjavur. Dr. Shetty has also made an outstanding contribution to research with multiple publications, 4 patents, and multiple awards for best scientific papers. He has served as the organizing secretary for major national conferences, guided several funded research projects under ICMR and DHR, and is a fellow of the National Foundation of Clinical Forensic Medicine. Sir will be joining us shortly. I now invite our chairperson, Dr. Mala Kamboj ma'am, to take over the proceedings of the scientific session and introduce our distinguished keynote speaker, Dr. Ujjwal Bhaval sir.
Good morning, everyone. Thank you very much. I would like to introduce the next speaker for today, Dr. Ujjwal Bhaval. He will speak or share his thoughts on the cancer clock, DEC1, DEC2, and hypoxia and tumor progression. Dr. Ujjwal is a distinguished Japanese researcher who currently serves as assistant professor at the Research Institute of Oral Science, Nihon University, School of Dentistry at Matsudo. A PhD graduate of Hiroshima, he has built an illustrious academic and research career across leading institutions in Japan, South Korea, and India, contributing extensively to molecular pathology, biochemistry, and translational oral science. His prolific research encompasses aging, cancer biology, stem cells, immunology, and molecular medicine, earning him numerous international awards and editorial roles in reputed scientific journals. Renowned for his rigor, innovation, and global collaborations, Dr. Bhaval continues to advance cutting-edge research with remarkable depth and dedication. So we are delighted to have you with us today, and I invite you to take over and please begin with the proceedings. Thank you, Dr. Ujjwal.
All right, thank you, ma'am. It's a great pleasure to be in this prestigious event of 32nd IAOMP meeting. And I'd like to congratulate the organizing committee and thanks them for inviting me to this event. And also the environment in the ITS Dental College is remarkable that I wish I would be a part in any sense of this school. So my talk is mainly focused on molecular biology in relation to molecular pathology. So as you see that it's an hypoxia, so I will go through the hypoxia, the basic slides on hypoxia for a few minutes, and then I will go forward to the main topic on transcription factors and hypoxia relationship. So this slide shows traces major milestones of tumor hypoxia research in leading to the discovery and characteristics of hypoxia-inducible factors. And as you know, it honors the Nobel laureates in 2019 that for uncovering how cells sense and adapt to oxygen via the heat pathway. It also announces the 2019 Nobel Prize for discoveries of cellular oxygen sensing and adaptation mechanisms. So this is the slide summarizes the HIF-1 alpha signaling pathway showing how cells regulate gene expression in response to oxygen levels. And here you see it illustrates the wide physiological and pathological impact of oxygen sensing across health and disease. So this slide shows how HIF modulates the iron metabolism and erythropoiesis, providing the therapeutic impact for anemia in patients with chronic kidney disease. As you know, that it shows that hypoxia at high altitude causes hypoxic sickness. It's an altitude sickness, and this is used by the athletes for performance adaptation. And who the PhD or master students work on hypoxia, you can understand the differences. The standard oxygen level in cell culture exceeds the physiological oxygen level found in tissues. And this slide depicts the hypoxic induce the regulation of more than 4,000 genes driving metabolic, vascular, and hematopoietic adaptation to hypoxia. And this is the slide that describes that hypoxia-induced transcription factors regulate or facilitate the influence of the both protective and harmful disease mechanisms. As you see, this slide illustrates the key cancer hallmarks, including angiogenesis, metabolism, and metastasis. And this slide shows the stress stimuli to modulate HIF1 activity, altering gene expression, and contributing to disease pathogenesis. This is a slide that shows that hypoxia inhibits regulates key cancer hallmarks, driving multiple oncogenic processes. And this is the slide of hypoxic tumor microenvironment, and it drives to survival, angiogenesis, resistance, and cancer recurrence. As you see the oxygen level, if you compare the oxygen levels in normal versus tumor cells, you could understand that cancers are markedly more hypoxic. And this slide shows that the oxygen-dependent stabilization of HIF1 alpha protein under hypoxic conditions in Western blot analysis. It shows a microarray data revealing thousands of genes up or down regulated in response to hypoxia. And this is a slide that depicts the hypoxia-inducible genes via microarray scatter plots and identifying the HIF1 alpha target genes like VEGF, DEC1, DEC2, and BNIP3. So this is the final slide on hypoxia that summarizes the HIF1 alpha regulation and its integration with oncogenic pathways driving tumor survival and metabolism. We also have HIF1 alpha transgenic mice constructed in our lab to perform the tumor or cancer experiments. And this is another slide that you know, in 2017, the Nobel laureates on clock genes. And it shows that how cells keep time linking circadian rhythm and oxygen regulation. In our lab, we focus on clock genes and hypoxia for the last 25 years. So what is circadian rhythm? Circa means about, and dian means a day, and this is about 24-hour cycle. And all the living phenomena should have the circadian rhythm. And this is a slide that summarizes how we can understand the effect of circadian rhythm, not only in our brain, but it can also work in the peripheral tissues. So what will happen if there is any disturbances in the circadian rhythm? We may have certain cancers along with other metabolic syndromes that influenced by clock genes. And we have published so many papers on clock genes and hypoxia, and we found our transcription factor DEC is one of target of hypoxic marker HIF1 alpha. And we also confirmed that DEC1 and DEC2 can transcriptionally regulate mismatch repair gene MSH1. So what is DEC? This is the transcription factor that we cloned in our laboratory in Hiroshima University in 2000 and published in the journal Nature. And this molecule works in the circadian rhythm, and now it has been established as a multifactorial transcription factor. So we can understand the circadian rhythm not only in cancers, but in human gingival fibroblasts and also human mesenchymal stem cells. How could we maintain the circadian rhythm? So here is a slide that shows the circadian rhythm in SMAC3 knockout mice in our lab. And you can understand the differences of the circadian rhythm behavioral test in mice experiments. We also focus on other markers like the DEC1, DEC2, and period 1 to understand the gene expression, messenger RNA expression in these circadian rhythm time points. And here is an alterations of these time points in DEC1, DEC2, and period 1 protein expression. So finally, if we overexpress SMAC3, then it can upregulate DEC1 and downregulate DEC2 and period 1. We also confirmed in a wound model in tongue, it's a mice experiment, and DEC1 expression was significantly reduced in wound sites of the SMAC3 knockout mice. So finally, we confirmed the cell motility in these experiments, and the SMAC3 knockdown reduced the cell motility while DEC1 overexpression suppressed the wound healing. We also confirmed our data using DEC1 overexpression model in proliferation experiments. So finally, how can we modulate these genes that if we overexpress DEC1, then E-cadherin and the proliferation marker, PCNA, will be reduced in line with DEC2 expression. So this is a summary of the circadian rhythm of DEC1, DEC2, and period 1 that shows that the SMAC3 can regulate DEC1 expression, and it can suppress DEC2 and period 1, leading to wound healing and cell proliferation. We cannot find this kind of circadian rhythm in cellular experiments using the serum shock experiments, not only in human cancer cell lines, but in other cell lines we could do this kind of experiments. And I'll show you some slides on DEC2 and VEGF is a vascular endothelial growth factor. So we focus on normoxia and hypoxia experiments, and VEGF, DEC1, DEC2, and HIF1 alpha, those are hypoxia-related genes. So you can understand the differences of the expression pattern of DEC1, DEC2, and HIF1 alpha at the different time points. So when we use the cancer cell line in cellular experiments in normoxia and hypoxia, DEC2 expression was significantly decreased with the DEC2 knockdown, while VEGF was significantly upregulated. So we could understand that there might be an inverse correlation between DEC2 and VEGF. So this is another assay that's called the luciferase assay, since my major is molecular biology, and we used to perform the interaction of protein-protein interaction or binding sites. Here is another example of luciferase assay to understand the binding between DEC2 and HIF1 alpha. Here is immunoprecipitation. It also showed that the DEC2 can bind to HIF1 alpha. So the next question is, where can it bind? So we have to screen the promoter region of the DEC2 gene to find the binding site so that we can understand that it works. So here we did the CHIP assay. It's a chromatin immunoprecipitation assay, showed that DEC2 specifically binds to the HRE. It's an hypoxia response element in the VEGF promoter to regulate the expression of VEGF. So these are the circadian rhythms present in tissues for VEGF and DEC2. So we summarize this data using this slide that in normal condition, in normoxia, HIF1 alpha is degraded, but in hypoxic condition, it is oxygen-dependent stabilization here, and it can bind with ERT1 and HRE, hypoxia response element, to induce the transcriptional activity of VEGF. I will next show you some slides on DEC1 and proliferation marker cyclin D1. We could do some immunohistochemistry to understand the expression pattern of DEC1 and cyclin D1. But since molecular biologist, we would like to know the interaction between DEC1 and cyclin D1 to suppress the cancer proliferation and metastasis. So these are the cellular experiments that showed that DEC1 overexpression can reduce the proliferation. We then performed luciferase reporter assays, real-time PCR, CHIP assays, Western blotting, and another CHIP assay to understand the effect of DEC1 and in relation to cyclin D1. So we could find that cyclin D1 is a direct target of DEC1, and we also performed the immunohistochemistry in our lab, and we used the human oral cancer specimens, and you can see the differential localization of DEC1 and cyclin D1. It's cyclin D1 is mainly focused on localized in the SIP and the basal layer, while DEC1 is the spinous or granular layer locations. But when DEC1 was highly expressed in carcinoma tissues, cyclin D1 was significantly decreased. So we assume that there might be an inverse relationship between DEC1 and cyclin D1. So this is the data that we could understand that opposite expression pattern between DEC1 and cyclin D1. So next we focus on irradiation. When we irradiate the cells, then DEC1 expression was significantly increased, but cyclin D1 expression was decreased. And we can understand the nuclear translocation because DEC1 is a transcription factor and it locates in the nucleus. And this slide showed that nuclear DEC1 expression was significantly increased upon irradiation. We also focus on ROS, reactive oxygen species. It's an oxidative stress in carcinoma. So then we focus in the cellular experiments and DEC1 overexpression and irradiation can induce the ROS, reactive oxygen species. We have animal experiments. We inject the human oral carcinoma cells into the mice, and then we irradiate the mice xenograft model. And we found that when we irradiate mice, and the DEC1 expression was significantly increased while the cyclin D1 expression was downregulated. So we confirmed this data using this model that irradiation can induce ROS, reactive oxygen species, and leading to the phosphorylation of AKT expression. It can also induce DEC1 expression to suppress the cyclin D1 expression and suppress the proliferation and invasion in carcinomas. I'll go through some apoptosis data. So in cellular experiments, if you want to target apoptosis, it's pretty common to understand the tunnel staining or the other DNA fragmentation staining in the cellular experiments. If we focus on the molecular mechanisms, in these experiments we use human breast cancer cell lines. Since I completed my PhD in the Department of Pathology in the Medical School of Hiroshima University, so we do have many works, not only in oral cancer, but other cancers, pancreatic cancer, prostate cancers, and cervical cancers. So those cancers also we have published so many papers together. So here is a breast cancer work, and this slide showed the siRNA knockdown and the upregulation in response to TNF alpha. And this is another paper published from our group in Nature Cell Biology in 2008 that showed that it's EM2-related molecules. It's an SMAD binding element, SBE, present in DEC1 to understand the transcriptional activity and epithelial mesenchymal transition, EMT. So here is some data using cancer cell lines, and these results show that TGF-beta is upregulates DEC1. And we have also performed some invasion assay to understand this relationship. Finally, we focus on the pancreatic cancer tissues to understand the apoptotic invasion in the cancer tissues compared to the adjacent non-tumor tissues. So there are many upstream and downstream factors of DEC, and we have already published these papers, including Begia, cyclin D1, and P53, and other SMAC3, snail, slug, and claudins. We next focus on another molecule, it's a twist1. It's also a mesenchymal marker. So we used some odontoma tissues as well as oral cancer tissues to understand the expression, messenger RNA expression of DEC1, DEC2, and twist1. And we have the biochemical analysis using the promoter activity of the twist1. And if you look at twist1, if you screen the twist1, there are two key boxes in the promoter region. And we have also the mutation in the E box of the twist1 promoter. So in normoxia and in hypoxia conditions, we have the messenger RNA expression levels between DEC1, DEC2, and twist1. We have also performed the CHIP assay to understand the binding between DEC1 and DEC2 and twist1. Finally, we focus on animal experiments, and this is a melanoma experiment, and it can have some metastasis into the lungs. So we isolate the lung tissues as well as the spleen tissues because the spleen tissues are devoid of immune cells. If you focus on NK cells, natural killer cells, or T cells, or B cells, spleen is the best tissue to understand the cell population in T cell, B cell, and NK cells. So we focus on NK cells and T cells regulation in metastasis, and NK activity was significantly downregulated in DEC1 knockout mice. We also performed the melanoma model, and then we showed this data using flow cytometry to understand the cell population. NKp46 is a subset of NK cells, and CD11D that showed the cell population was significantly reduced in DEC1 knockout mice. We have also performed the lymphocytes percentage, and that also showed the similar pattern in immune cell population in metastasis. Finally, we focus on the immunohistochemistry that showed that DEC1, DEC2, and twist1 in the control mice. This is wild-type mice, and this is the DEC1 knockout mice and DEC2 knockout mice to show the differences between the DEC1 and DEC2 population, staining population in these tissues. We performed the messenger RNA expression patterns. And finally, this is the last slide that I think I could complete it by 30 minutes. And the DEC1 and DEC2 both can bind to EVOX of the twist1, and it can suppress twist1 through the EVOX. And this suppression can be activated by the natural killer cells that can suppress the metastasis in the animal models. And that's the last slide. Thank you. Thank you for your listening. And I'm happy to have questions. Thank you so much.
Thank you, Dr. Ujjwal. That was indeed very insightful. Any audience, if anybody has any questions or queries from the audience, I think he'll be happy to take.
I'm very sorry that all the talks are in molecular level. I do not have so many slides on immunohistochemistry or AT staining, but since I do not have an access to the human samples in Japan, so I'd like to collaborate with any of you so that we can do more works using human samples and immunohistochemistry at your facilities if possible. Thank you.
I think we have one query from Dr. Rachna.
Yeah, I think the same line that sir was just mentioning. I was thinking when I saw that slide of slug snail twist. So that is the pathway where you get the tumor budding. So I was exactly thinking that correlating this with the histopathological parameters would be really nice. There would be some message for the pathologist what we really
That's a great comment. I appreciate it if someone raises hand with a big heart. Whenever you collaborate, you need to facilitate. There's an give and take, and we could understand that there might be some regulations in the government level in India. Since my hometown is in Kolkata, any Kolkata people can raise your hands. Oh, great. Yes, thank you so much. Yes, please, ma'am.
Thank you, Dr. Ujjwal. We too at our center have been pursuing research on HIF1 alpha. We concluded 2 studies, one on oral squamous cell carcinoma and OPMDs, seeing a combined role of plasma dendritic cells along with it, and we also did one on periapical tissue. So yeah, wish you all the best and thank you so much for today.
That's a great comment. I think because cancer is markedly more hypoxic, So if you focus on HIF1 alpha and VEGF, and there are certain new hypoxic markers that are not examined in oral cancer tissues. So that would be more interesting and a great avenue to conduct research for the PG students. Thank you so much.
Thank you so much, sir, for such a thought-provoking and insightful presentation. I'm certain the audience has gained a wealth of knowledge from this enlightening session. May I now request our esteemed chairpersons, Dr. Mala Kamboj ma'am and Dr. Pushpraj Shetty sir, to felicitate our distinguished keynote speaker, Dr. Ujjwal Bhaval sir. Can I have a huge round of applause, please? Moving on, I now request Dr. Rajiv Desai sir to present a token of appreciation to our chairperson, Dr. Mala Kamboj ma'am. I also request sir to felicitate our chairperson, Dr. Pushpraj Shetty sir. Before moving forward, I would like to call a volunteer on behalf of the Nepalese Association of Oral and Maxillofacial Pathology to share some information with us.
A warm greet from Nepal. It's me, Dr. Susma Adhikari, a final year PG resident from Kantipur Dental College, Kathmandu, Nepal. On the behalf of NAOMP, we'd like to invite you all for our upcoming second national conference going to be held in Kathmandu, Nepal. The conference is aimed at sharing the knowledge and strengthening the bond between the like-minded people of two beautiful neighboring nations. Will ensure that you have a memorable experience in Nepal. Thank you, and thank you all the organizing team for providing me some time to convey my message. Thank you so much, sir.
Now, let's begin with the prestigious Dr. R. Vishwanathan Endowment Lecture, which will be delivered by our keynote speaker, Dr. Mahija Janardhan Ma'am, on the topic Fibro-osseous lesions of the jaw, diagnostic confusions and prognostic dilemmas. To chair this important session, I would like to invite on the stage our respected chairperson, Dr. A. Sudarshan Kumar, sir. Sir is a professor, head of the Department of Oral Pathology at GSL Dental College and Hospital, Rajahmundry. Sir is a recognized PhD guide under the Dr. NTR University of Health Sciences and has multiple ICMR-funded short-term research projects to his credit. Respected for his academic leadership, meticulous diagnostic approach, we are privileged to have with us today an accomplished academician, dedicated researcher, and a guiding mentor. Sir, we warmly welcome you and invite you to chair this endowment lecture. A huge round of applause for Sir, and we welcome him. I would also like to invite on the stage our accompanying Honorable Chairperson for the endowment lecture, Dr. Nadeem Jedi, Sir, President-elect IAOMP. Sir currently serves as the Professor and Head of the Department of Oral Pathology at Thai Mugambagai Dental College and Hospital, Chennai, and also as a Joint Registrar at Dr. MGR Educational and Research Institute. Sir has over 2 decades of academic and research experience and has guided numerous postgraduates and PhD scholars. His excellence and leadership have earned him multiple honors degrees, including the C.V. Raman Research Publication Award, the Fellowship of IAOMP, and the Leadership Award in Oral Pathology. Let us all welcome Sir with a huge round of applause. May I now request the esteemed chairpersons to continue with the proceedings of the scientific session and introduce our eminent keynote speaker, Dr. Mahija Janardhan Ma'am. Over to you, sir.
Thank you. Good morning, everyone. It's my privilege to introduce the speaker of this session, Dr. Mahija Janardhan, who is a distinguished academician, researcher, and mentor with over 2 decades of teaching experience in oral and maxillofacial pathology. She obtained her BDS and MDS from Mahatma Gandhi Postgraduate Institute of Dental Sciences, Puducherry, and currently serves as professor at Amrita School of Dentistry, Kochi. Her areas of expertise include oral cancer research, tumor immunology, and diagnostic oral pathology. She has received multiple Best Paper Awards at national conferences and serves as executive editor of the Journal of Oral and Maxillofacial Pathology. Dr. Mahija also contributes actively to professional organizations as Honorary Secretary of Kerala Society of Oral and Maxillofacial Pathology and continues to inspire through her leadership, research and mentorship. Madam, we are honored to have you with us today. I would like to invite you to kindly take over and begin the session. Thank you.
Thank you. Respected chairpersons, senior members of the fraternity, my friends and my dear students, warm good morning to all of you. I bring wishes from Department of Oral and Maxillofacial Pathology, Amrita School of Dentistry, Kochi. I feel truly privileged and deeply humbled to deliver this endowment lecture in the name of Dr. R. Vishwanathan, who is fondly remembered as Bhishma Pitamaha of oral pathology. I like to extend my sincere gratitude to the Association of Oral and Maxillofacial. So going to the theme of this conference, dilemmas and diagnosis, I'll be talking on one of the most challenging areas in academic pathology, where we as diagnostic specialists play an integral role in deciding the prognosis of the patients by providing an accurate diagnosis. So to the topic, fibrous lesions of the jaw, diagnosis and fibrous lesions are a diverse group of disease processes characterized by replacement of normal architecture by heterogeneous connective tissue containing mineralized material. So, lesions with diverse etiology, pathogenesis, clinical behavior, and prognosis have been brought together under the same umbrella as they share similar microscopic features. So the term as such is not a specific diagnosis, but however we require a specific diagnosis because these lesions are not treated in the same way. Some of them do not require treatment at all, while others might require surgical recontouring for cosmetic reasons, or sometimes in case of allergy, you might have to go for a complete removal. So the prognosis is purely dependent upon our diagnosis. However, diagnosis is not very easy because we cannot, in most cases, we won't be able to diagnose purely based on histopathology alone. We might be dependent on the clinical features and radiographic features for an accurate diagnosis. The confusions in the diagnosis has led to a lot of classifications. And probably if you Google or if you look for the article, you might see lots of classifications and you might require a special classification to classify these tumors. That many classifications we have in hand. But however, the one which is widely accepted is the classification which has been put forward by Walden in 1993. He classified fibrous lesions into three groups: the developmental, reactive group of lesions and neoplastic group of lesions. The developmental one include fibrous dysplasia, which can involve a single bone or multiple bones. So the terms are monostotic fibrous dysplasia and polyostotic fibrous dysplasia. The reactive group of lesions are termed as cementoosseous dysplasias, which is further subcategorized into periapical, focal or florid, depending upon the clinical presentation. And the third group is the neoplasm, which is termed as ossifying fibroma. So WHO 22 places these group of lesions in chapter 7 on odontogenic and maxillofacial bone tumors, and there are around 6 lesions which are included. So the two lesions are actually new entries in 2022. They are the familial florid cementoosseous dysplasia and segmental odontomaxillary dysplasia, and there's a change in the terminology of juvenile semimatoid ossifying fibroma. It was previously known as juvenile. Now the term juvenile has been dropped because it is a misnomer. It occurs in wide age group and much more common in adults when compared to the subacular variant. So now the question is, we have only 6 lesions which are included in the fibrous category. Why is it that it's so difficult? Like, we are okay with odontogenic tumors or salivary gland tumors which are more in number. We have to differentiate just between 6 lesions.
The answer is, even if the classification includes only 6 lesions, you have a lot of them, lot of lesions lying outside the classification, which has fibrous picture, which shows clinical, radiographic and histopathological features which resemble fibrous lesions. They include reactive lesions, they include neoplastic lesions involving the bone, and also you might have noticed that some of these lesions are odontogenic lesions. With such a good number of lesions in hand, it is very difficult to come to a conclusive diagnosis, and while diagnosing, we need to consider all these lesions to come to a conclusive diagnosis, and it makes it very complex. So now let me take you to a very common clinical scenario which all of you would have experienced in your routine practice. A clinician diagnoses a lesion as a fibrous lesion when a patient comes with a swelling and radiographically they present with a fixed radiopaque picture or a complete radiopaque picture. He takes a biopsy and he sends it across to us for diagnosis. We, on our part, we see the slide under microscope. We see that there is fibrous component, there is osseous component. We are pretty convinced that this is fibrous lesion. But the problem is we do not have any, he doesn't provide us any clinical background. And in the absence of a clinical background, we will be left with no option than reporting the lesion as a fibrous lesion. We won't be more specific with that. So when the clinician receives our report, what will we do? We are just putting ball on surgeon's court now. He won't be able to decide on how to go about it with the treatment. So, our diagnosis of fibrous lesion is almost meaningless. It's as good as not reporting at all. So, the whole focus of my presentation will be, how can we give a more specific diagnosis? How can we avoid giving a diagnosis of fibrous lesion? Now, the challenges, as we have seen, lack of clinical background is one of the most common challenges which we face with diagnosing a fibrous lesion. The other challenges are, most of the time, or at least sometimes, we won't be getting a representative biopsy. The lesion is growing within the bone. Naturally, the bone responds by forming reactive bone. So the bone gets thickened. So the biopsy which we get mostly will be a normal bone or reactive bone. Third is overlapping histopathological features, and when we come across an overlapping feature, in case of spindle cell neoplasm or round cell neoplasm, we go for immunohistochemical markers, IHC markers. Here we do not have any reliable marker we can depend on to have a conclusive diagnosis, and molecular cytogenetics is still in very early stage. Probably we have a molecular marker, DNA is one mutational analysis for fibrous dysplasia, otherwise we do not have any marker. So ultimately, we are left with HLD stage slides where we can make the diagnosis only based on morphological features. So this is a diagnostic algorithm which is followed for diagnosis of fibrous lesions. So generally, we need to do a pre-operative analysis. This is mainly for the clinician because all cases of fibrous lesion, biopsy is not indicated. In the case of cementosus dysplasia, biopsy is contraindicated because the bone is hypovascular. So once we expose the bone to the oral environment, there can be development of osteomyelitis, and osteomyelitis do not respond to the usual treatment modalities. It will be very difficult to manage. So ideally, cementosus dysplasia, biopsy is contraindicated. So it becomes the responsibility of the surgeon to decide or to rule out cementosus dysplasia before going for a biopsy. So rest of the lesions, biopsy can be done, and as we have already discussed, ultimate diagnosis depends upon all 3 parameters: clinical features, radiographic features, and microscopic analysis. So now, how do we go about now? First, let's see how we diagnose a lesion clinically. For clinical diagnosis, you can divide fibrous lesions into 2 broader categories: symptomatic lesions or asymptomatic lesions. Asymptomatic lesions are the one where the patient is inside the bone and patient is not awake. So cementoosseous dysplasias are generally asymptomatic. So an asymptomatic lesion could represent a cementoosseous dysplasia, or it could be an early stage of a lesion which can become symptomatic at a later stage. But whatever the case may be, ideally, if the lesion is asymptomatic, better do not attempt a biopsy. You can always keep the patient for a follow-up, and if at all a swelling develops at a later stage, you can go for a biopsy. Now coming back to cementoosseous dysplasia, further subcategorization of cementoosseous dysplasia can be done based on the clinical features. So as you can see here, a unifocal lesion which is occurring in the mandibular premolar region most likely will be a focus cementoosseous dysplasia, whereas multifocal lesions occurring in the pedioapical region of the mandibular anterior region could be a pedioapical cementoosseous dysplasia. And florid cementoosseous dysplasias are generally widespread and asymptomatic usually, but sometimes, if at all osteomyelitis develops, patient might complain of pain. Symptomatic lesions usually present as a swelling at the site of the involvement, and it's not as easy as diagnosing a symptomatic lesion. Here you have to have a systematic approach where you have to look at the family history, age, race, the site of involvement, the distribution of the lesion as unilateral or bilateral, localized or diffuse, and rate of growth, whether it's a slow growing lesion or a fast growing lesion. All this gives you a clue regarding the diagnosis, and finally you will be able to reach a clinical diagnosis. Once a clinical diagnosis is arrived at, you need to look at the radiographic features, and in the radiograph, all the lesions, all fibrous lesions generally, they pass through different phases. There is a early phase where it is completely radiolucent, where the lesion is predominantly fibrous, followed by a mixed radiopaque radiolucent phase where there is combination of fibrous and osseous component histologically, and finally as this bone, as this mineralized material mature and they grow, it becomes completely radiopaque. So depending upon the variations in radiolucency and radiopacity, probably you can assess the stage of the lesion. Similarly, other parameters, radiographic parameters like whether they are diffuse or localized, are they showing any specific pattern? Like in case of fibrous dysplasia, we know it shows the typical groundless pattern. And the other parameter which definitely will help us is the periphery of the lesion. As you can see here, the first image is actually on the left-hand side, is the fibrous dysplasia, where the lesion merges with the bone and there is no clear-cut demarcation between the lesional area and the normal bone. Okay, if you want to, sometimes histologically, it might resemble an ossifying fibroma. In such cases, the other radiographs represent the ossifying fibroma where you have a well-defined border. So all these parameters will be really useful for us in arriving at a diagnosis. So combining the clinical features with radiographic features, you'll be able to reach a provisional diagnosis. But our final diagnosis is definitely in our hands. But unfortunately, we don't have many things to look at. We have only two components to look at. One is the fibrous component and the other is the osseous component. And we need to depend on the slight subtle differences between these parameters to ultimately come to a diagnosis. So in the connective tissue, in the fibrous component, sometimes you might see connective tissue which is hypercellular, immature hypercellular, or sometimes you might see proliferating spindle cells going in a storiform pattern, and sometimes you might see mature hypercellular areas. Similarly, in the osseous component also, you might see variation like lamellar bone. Sometimes you might see immature bone, immature woven bone as trabeculae with the osteoblast entrapped within. And you might also see sometimes osteoid in the form of lazy osteoid. Also, sometimes you can see that this osseous component gives a peculiar pattern, like Chinese letter pattern in the case of fibrous dysplasia, ginger roots in the case of cementoosseous dysplasia, or cemental woven. You can see both in ossifying fibromas as well as cementoosseous dysplasias. So all these features also gives us a clue regarding the diagnosis. So that is the basic about fibro-osseous lesion. Now, before going into cases, real scenario of seeing cases, I'll give you a short break just to activate your brain. Okay? So this is something which we all would have done as a kid, right? Spot 10 differences between two similar images. So done? So if you're good at doing this, you might be good at diagnosing a fibrous lesion also, because we are going to deal with similar looking lesions. But of course, with a background of knowledge. So now let's see some cases. Case 1. This patient was a 33-year-old female patient who presented with painless enlargement of the right upper jaw in relation to molar teeth for past 1 year. Extraorally, a slight swelling is there, slight asymmetry is there, but the lesion was seen in the posterior maxilla as a well-localized swelling. So here, based on we need to have a systematic approach, you have to have a checklist. So the age is third decade, site is posterior maxilla, it's unilateral, localized and slow growing lesion. So with all these features, my diagnosis was ossifying fibroma because it occurred late and also it was a localized, slow growing lesion. But then when we looked at the X-ray, this is a very simple X-ray, this is just an IOPA. In the X-ray, you can see that in the IOP radiograph, you can see that the lesion, there is no clear-cut demarcation. The lesion is merging with the adjacent normal area. And there's a tip, if you keenly observe, there is a typical ground glass picture over there. So most likely, fibrous dysplasia. So it's diffuse ground glass, periphery glands to the adjacent bone, most likely fibrous dysplasia. But then, similar picture you can also get in hyperparathyroidism. So these are the two diagnoses which I thought of. But then when you look at the premolar region, that's a normal bone. Look at the lamina dura, it's well distinct and normal. You can see the periodontal ligament space also. But look at the lesional side. The lesional side, you are not able to make out the lamina dura clearly, and there is narrowing of periodontal ligament space. So most likely this is going to be a fibrous dysplasia clinically because hyperparathyroidism usually shows symmetric widening of the periodontal ligament. So clinical diagnosis is fibrous dysplasia. Now let's have a look at the histopathology. So this is what we saw under microscope. So two components, fibrous component and osseous component. And fibrous component, you will see that it is moderately cellular. Within the moderately cellular background, you are able to see trabeculae of bone. It is not mature bone, it's immature bone. And you can see that peritrabecular clefting very clearly. That is thought to be a unique feature of this particular lesion. And overall, if you look at, there's a clue here. There's a clue here. Alphabet soup appearance. And look at the woven bone. It is woven bone, immature bone, it's not mature bone, it's not lamellated. You can see slump osteoblast, and there is no osteoblastic rimming. It merges with the other image, you can see that it merges with the bone, superficial bone, there's no demarcation. So diagnosis is clear. Immature bone, immature stroma, curvilinear trabeculae which fail to fuse. Chinese letter, that's how we all learn, but nowadays I think to the new generation people, they have changed it to alphabet soup pattern, and no osteoblastic rimming, presence of peritrabecular clefting, margin fusing with the normal bone. Diagnosis is fibrous dysplasia, it's involving only a single bone, it has to be monohystractic fibrous dysplasia. Now the second case, this patient was a 52-year-old male patient, a progressive painless swelling in the left side of the mandible, which was present since childhood. That has to be underlying childhood. That's an important relevant point. And he gave history of surgical treatment 20 years back. So you can see that there is a swelling in the left side of the mandible. And radiograph, this is an OPG. Radiograph shows mixed radio-opaque, radiolucent picture. Margins are not clear. There's bowing of the lower border. Bowing of the lower border. Diagnosis. So I thought of juvenile trabecular ossifying fibroma first because showing mixed picture and bowing of the lower border is typical of juvenile ossifying fibroma. This was present in childhood. But only point which was going against this was it's a little more aggressive tumor. Will it last this long? So I added one more differential diagnosis, fibrous dysplasia. And I considered cemento-ossifying fibroma also because it can also form this bowing of the lower border, but recurrence, it's doubtful. So, but this is what we saw under microscope. When they took the incisional biopsy, this is what we saw. It is obviously a osteolytic lesion, but within the bone, we are able to see some spaces filled with RBCs, and all the spaces didn't have a endothelial lining. Suggestive of aneurysmal bone cysts, but there were no giant cells. However, the surgeons went ahead with surgical resection because it was a lytic lesion of the bone, it was an extensive lesion of the bone, and that was the specimen we got. But there was nothing like blood-soaked sponge appearance. Nothing like a characteristic feature of ABC. And excisional biopsy also we saw very similar feature like large dilated spaces with RBC, no giant cell, no endothelial lining. But still we thought it could be, there's a variant of ABC where you do not see giant cell, so it could be ABC. But then, even in the bone we are able to see something like this, very similar picture. But other sections we were able to get this picture. That is moderately cellular fibrous connective tissue, bony trabeculae, and which failed to fuse, curvilinear, no osteoblastic rimming, and the lesion merging with the superficial bone. And the one which you see on the left side is a mandibular canal. You can see the cortical bone and you can see the ossicles there, trabecular bone there. Diagnosis, fibrous dysplasia. On further evaluation, we found that apart from mandible, there was involvement of multiple bones in the craniofacial skeleton like maxilla, rhizoma, temporal bone. All these bones were involved, but of course there were no long bone and vertebral involvement. So the diagnosis was craniofacial fibrous dysplasia associated with ABC or stromal cystic degeneration. Both ABC and stromal cystic degeneration are a complication of fibrous dysplasia, long-standing case of fibrous dysplasia. So when you look at these two cases represent two clinical manifestations of fibrous dysplasia. The first one occurred much late, but it was a very minimal involvement was there, whereas the second lesion was a long-standing lesion which started from childhood and remained till 52 years. So it's a long-standing lesion, and we have seen complication also in that. What happens if the lesion is there for a long time? So ultimately, why there is difference in the clinical manifestation? Because we know that fibrous dysplasia is a developmental disease caused by mutation of NAS1 gene, and depending upon the time period during which mutation takes place, there can be variation in the clinical manifestation. So the first case probably the mutation would have taken place postnatally, after all these progenitor skeletal stem cells have migrated to the involved area. Whereas the previous one would have happened much later, but most likely in the late embryonic phase. If it was in the early embryonic phase, the manifestation would have been much more severe. The patient would have had Albright syndrome, which is characterized by multiple bone involvement, subfibrillary pigmentation, and endocrinopathies. So prognosis implication, histopathology does not give us any clue on biological behavior, but of course clinical features might give. Monostotic are said to be stabilizing by puberty in most of the cases, and polyostotic, it can stabilize, but if it is progressing to further, it is not a good sign. Similarly, they say that alkaline phosphatase level also positively correlates with the severity of the disease and could be used as a parameter for prognosis. And complications, non-specific cystic degeneration or aneurysm and marital transformation is also a complication of fibrous dysplasia. So now let me take you to the third case. This patient actually, we didn't see the patient, we got a slide for second opinion. And this slide was from a patient who was 12-year-old female patient who presented with swelling in the right side of the mandible for past 1 year. And she had a report also with her, and her previous biopsy report said that it was a case of fibrous dysplasia. So when you look at the slide, okay, it looks like fibrous dysplasia. You can see bony trabeculae against moderately cellular fibrous connective tissue stroma. There is a belly trabecular clefting. Goes with fibrous dysplasia, and the lesion was merging with the bone, superficial bone. But there was something unusual with this case because when we saw the bone trabeculae, it was not the typical woven bone which we get in fibrous dysplasia. It was a bone which was mature bone which was undergoing remodeling. You can see that there are a lot of reversal lines, and you can see that there is resorption, active resorption. You can even see multinucleated giant cells over there. And some areas, the bone was well lamellated bone, mature bone. Mature bone can occur in fibrous dysplasia of the maxilla, but again, this is seen in as the lesion matures. In a 12-year-old, we don't expect to see lamellated bone. So, considering all these features and the inflammatory infiltrate which was seen, I suspected chronic osteomyelitis. And then the patient was put on antibiotics. And for 6 months, we didn't know anything about the patient. When she came back after 6 months, she gave history of recurrent pain and swelling of the right side of the mandible. No obvious source of infection, and it was not responding to antibiotics. Bacterial culture was negative. And she also complained of pain in knee when she came next time. And when the whole body MRI was done, there was osteomyelitic changes in both mandible and distal femur. So we wanted to see the slides again. So there was curvilinear trabecular bone with reversal line, peripheral resorption, reactive connective tissue, all along with the clinical background goes with the diagnosis of chronic recurrent multifocal osteomyelitis. So chronic recurrent multifocal osteomyelitis is an autoinflammatory disease primarily occurring in children and adolescents. It's a little known disease. That's a problem. We do not know much about this disease, and we might end up underdiagnosing the lesion as osteomyelitis or misdiagnosing it as fibrous dysplasia. So diagnosis can be really challenging in the initial stages because only single involvement will be there, single bone involvement will be there, and in certain cases there are isolated lesion of the jaw also, which is termed as chronic non-bacterial osteomyelitis. And histopathologically, you will see features very similar to fibrous dysplasia, and they do not respond to conventional treatment for osteomyelitis. So the ideal doctors to treat them are the rheumatologists. We send this patient to a rheumatologist, and she is on tumor necrosis factor inhibitors right now, and her mandibular lesion has completely healed, but unfortunately she has developed lesion in the clavicle. She has developed psoriasis, but that's how the disease is. Psoriasis is also associated with this disease. So this case actually shows how the cause of the disease can be decided by a pathologist. How our diagnosis changed the course of the disease. Now, case 4. This patient was a 27-year-old female patient who reported with a swelling on right side of the lower jaw in 4647 region. It was of 2 years duration. So you can see a swelling, obvious swelling in the premolar region. There's obliteration of the vestibule. So this is how her CT looked like. There's a well-defined unilocular lesion and it's showing areas of opacification. Considering the site and the appearance of the lesion, we have considered odontogenic system tumor because it's occurring in the tooth-bearing area of the jaw. Then we considered cementosifying fibroma and focal cementosous dysplasia. Both occur at this site, but cementosous dysplasias usually do not give a symptom, like they're only seen as a swelling usually. Then incisional biopsy showed this. There is something like C-shaped trabeculae, and there is no clear-cut demarcation between the lesional area and adjacent bone. So we were totally confused because histopathology looked like fibrous dysplasia, but clinically it was not matching with fibrous dysplasia. So we asked for a repeat biopsy, but since the lesion was well localized and it was very small, we went for the excisional biopsy. And in the excisional biopsy specimen, we got this, you can see that there are a lot of trabeculae which are failing to fuse to each other, something like curvilinear. But deeper down, you can see that they are trying to interconnect. Okay, so definitely not fibrous dysplasia. But then, deeper down, there was the lesion was deeper down, and you can see that it was composed of fibrous connective tissue, and you can see numerous multinucleated giant cells distributed throughout. So what we were looking was not exactly a fibrous lesion, it was a giant cell lesion. And what we saw in the incisional biopsy was just a periphery of the lesion. So multinucleated giant cell, duplicate giant cell lesion. So we consider central giant cell granuloma, Brown's tumor of hyperparathyroidism, and juvenile ossifying fibroma, because juvenile ossifying fibroma can sometimes show, or usually shows, focal aggregates of giant cells. Now, when you come into the case of a giant cell lesion, you definitely need to rule out hyperparathyroidism. So we also sent for serological investigation, and the report came like this: vitamin level was low, her calcium was normal, but PPH was again high. Okay, so the diagnosis was Brown's tumor of secondary hyperparathyroidism. So she was referred to an endocrinologist where she underwent treatment for almost a year, and she is completely normal after that. Now coming to the case 5, this patient, a 21-year-old male patient who presented with a painless swelling in the lower left gingiva in relation to molar teeth, which was noticed 1 week back. So you can see a well-defined unilocular lesion in the periapical region of molar tooth, and the differential diagnosis because of the typical location, focal osseous dysplasia, cementosifying fibroma, and of course we considered odontogenic tumors also. So this was the microscopic appearance of the lesion. Obviously a fibroosseous lesion. You can see both osseous trabeculae and cementum-like globules. And it was a well-circumscribed lesion. It was a well-circumscribed lesion showing both osseous trabeculae and cementum-like globules. And some area it was looking like woven bone, which resembled fibrous dysplasia. But then you can see that there is osteoblastic rimming. And cementum-like globules had the brush border, typical brush border. So well-circumscribed lesion, mature connective tissue stroma, osseous trabeculae showing woven bone with osteoblastic rimming, and cementum-like globules showing brush border. All this suggests that it is a cementosifying fibroma. Now case number 6, this was a 10-year-old male patient, pain and swelling in the left side of the upper jaw of 6 months duration. So there's a swelling, obvious swelling in the left jaw, upper jaw, and you can see the obliteration of the buccal vestibule and a radiopaque lesion, well-defined radiopaque lesion. You can see that the canine and 2 premolars are impacted, undisplaced. And this is how the histopathology was. Very cellular connective tissue stroma, and you can see hypercellular areas alternating with hypocellular areas and areas of mineralization, obviously fibrous lesion. And the connective tissue component, you can see that they resemble atomesenchium. And you can make out that cellular and acellular areas. Ossifications, and you could see both ossifications and cementum-like globules, globular mineralization. So again, this is a case of cementossified fibroma, but very much different from the previous case which we saw. So there was an interesting finding in this particular case. We took a section of the tooth which was attached to the lesion, and you were able to see sulcus lined by sulcular epithelium, dentine, cementum, bone, and in between is the periodontal ligament. And the periodontal ligament appeared to be calcified. You can see a lot of globules, and the cementum seemed to be cellular. And you can see that these globules are entering into the bone. Basophilic globules entering into the bone. Since this cementossified fibroma arises from the periodontal ligament, this might be having some significance. And case number 7, this patient was a 34-year-old female patient who reported with painless swelling the right side of the face for the past 1 year. You can see a lesion involving the maxillary sinus completely. So this was how it was excised. The lesion came as whole, it shells out. And microscopically, it was a well circumscribed lesion, mainly composed of the fibrous connective tissue stroma, and in some areas focally, we were able to see some dystrophic calcification. And cellular stroma was giving this typical storiform pattern. Again, some areas showing calcification, and some areas it appeared to be globules of cementum-like masses, also cementum predominant lesion. Again, it is cementossified fibroma, another manifestation of cementossified fibroma. And a quick look through 2 more cases. This is again a case occurred in the maxillary sinus with clear evidence of its origin from the tooth. The second image probably can make out that the lesion actually started in relation to the tooth. It was well within the alveolus and which has expanded into the maxillary sinus. And the histologic features were overlapping features with previous cases. Another case, an extensive lesion of mandible. Usually they are said to be well localized, but here it's involving almost 1/2 of the mandible throughout. And histopathological features were consistent with cementossified fibroma, but some areas we were able to see there's a direct connection between the bone and the lesional area. But otherwise it was well encapsulated. So cementossified fibroma, as defined by WHO, it is a benign odontogenic fibrosis neoplasm. Even if the lesion has been removed from the classification of fibrosis lesion, when it comes to diagnosis, we have to consider them. It's a fibrosis neoplasm. And the controversy, it's always, ossified fibroma was a lesion which was haunted by controversies. But we thought that in 2017 they put it in odontogenic lesions. We thought everything is solved. But again, there are evidences coming up that there are lesions occurring in the frontal bone, nasal bone, maxillary sinus. I'm not very convinced that it is not odontogenic. And on to the areas of mandible, and which suggests that there exists a subset of cementossified fibroma which is not odontogenic. And clinical characteristics and histopathological findings, they show wide variation, whereas radiographic findings are the same for all these lesions. They are well demarked from the adjacent normal bone, and they shells out to the surgeon. Histopathological variation doesn't have any prognostic implication. Neoplasm requires surgical excision and recurrence are generally rare. Case A, this is from a 41-year-old female patient who presented with very similar lesion involving the maxillary sinus, but giving a very different picture. There is no capsule at all, and highly cellular fibrous connective tissue stroma with a lot of ossicles, osteoid spherules, that is the word. And these ovoid spherules where something like a basophilic calcification in some areas, but certain other areas show the central basophilic area surrounded by a peripheral osteoid rim. But of course, in the periphery of the lesion, we are able to see some bony trabeculae, osseous trabeculae. So unencapsulated lesion, hypercellular stroma of gland, ovoid and spindle cells, subhematoid mineralization, spherical ossicle with basophilic center and eosinophilic peripheral rim, no osteoblastic rimming. The diagnosis is subhematoid ossified fibroma. This patient, a 9-year-old female patient, presented with swelling of the left side of the mandible. Radiograph showing an expansile lesion with mixed radiopaque radiolucent picture, and histopathology, highly cellular connective tissue showing streaming fascicles of spindle cells and ossification in the form of osteoid as well as trabeculae. And the osteoid matrix was found to be merging with the connective tissue and hypercellular areas and hypocellular areas. And we were able to make out some atypical cells, mitotic cells, something like mitotic cells, but otherwise the cells were blank. There were no ATP at all in the cells. And focally there were aggregates of giant cells. So unencapsulated tumor, elongated strands of trabeculae with osteoblastic rimming, sheets of osteoid blending imperceptibly with surrounding stroma, the stroma exhibiting zones of variable cellularity and occasional mitotic figures. Focal aggregates of giant cell takes you to the diagnosis of juvenile ossifying trabecular variant. We might confuse it with low-grade osteosarcoma sometimes. Now the last case, this patient was we got the slides for second opinion, and the slides were from a patient who was 74-year-old male patient, and we got the following information. There was swelling in the left side of the lower jaw of 2 months duration. Clinical diagnosis was florid cementosseous dysplasia, and previous biopsy report said consistent with cementosseous dysplasia. Now let's have a look at the case. There was an obvious swelling. They said it is 2 months duration, and for 2 months it is not a slow growing lesion, it's a fast growing lesion, and obviously not a cementosseous dysplasia because cementosseous dysplasia usually doesn't produce this much of swelling. And histopathology, of course, showed some areas which resembled cementosseous dysplasia. We are able to see bony trabeculae, we are able to see cementum-like areas, and there were a lot of hemorrhagic areas. Everything went well with cementosseous dysplasia, but this was seen only focally. Rest of the area showed highly cellular stroma with bony trabeculae. You can see osteoid in between. And in between the tumor cells, you are able to see something called lazy osteoid. This is what is lazy osteoid. And the tumor cells are pleomorphic, shows vesicular nuclei. And you can, the other slide, left side, you can see that that is epithelioid morphology for the tumor cells. And atypia, lot of mitotic figures, around 4 to 6 mitotic figures per hyperfield we were able to make out. Chondroid areas. So the diagnosis is osteosarcoma. So this is a very interesting case for a critical analysis and an introspection because this particular patient, the first report came as cementosseous dysplasia. So where did they go wrong? Here, the clinician, it was a surgeon, oral surgeon, clinical diagnosis was given as cementosseous dysplasia. So what would have happened was the pathologist would have blindly or would have got carried away with the clinical diagnosis, and we sometimes do that. We try to fit in our diagnosis with the clinical diagnosis. Okay? And that's the reason why probably this was diagnosed as cementosseous dysplasia. So ultimately, how can we avoid that? So here, the clinical diagnosis was given by a surgeon who gave it as cementosseous dysplasia. It was actually not reported by an oral pathologist, it was reported by a general pathologist. somehow they got carried away with the clinical features and diagnosed it as cementitious dysplasia. So the message it carries is that you don't have to depend upon diagnosis, clinical diagnosis by a clinician. We can get the clinical information, we can get the radiographic information, and we can go through our own diagnosis, and we can correlate those features with the histopathological features, and maybe we'll get a better, accurate diagnosis there. So that is the message I would like to convey with this last case. And later we came to know that this patient had a history of laryngeal carcinoma, and he had undergone radiotherapy some 15 years back. So the summary is fibrosous lesion. The term fibrosous is just a histopathological description and not a diagnosis, and use the term only as a descriptive aid and not a final label. Incisional biopsies can be misleading, so interpret with caution. And meticulous slide review is vital to rule out the histologic mimics. And with a systematic multidisciplinary approach, most cases can be accurately diagnosed. So may his legacy, enduring passion, tireless effort, and wisdom continue to be a source of inspiration and moral direction to inspire us all. And I would once again like to, on behalf of my department, I would like to thank IAOMP, the Indian Association of Oral and Maxillofacial Facial Pathology, and Team ITS Ghaziabad for giving us this wonderful opportunity. And let me conclude with this simple but very insightful message from our Chancellor, Mata Amridandamayi Devi. Thank you one and all for your patient listening.
Thank you, Mahija. I think you really gave a wonderful lecture on fibrosous lesions. This is an oration lecture. I think we don't entertain questions from the audience. So with this, we conclude. Thank you very much.